Thank you so much, Dr. Muzagar, and thank you, Sandy, and thank you, Bahare, for inviting me to talk about, my favorite subject. It's really, not only my work, it's also a hobby, of course. And I actually was here at the ILC meeting 3 years ago. And here you can see that's what the talk was back then. Now more exciting with the Canadian ILC Foundation here. And, things have changed quite a bit. So this was back in 2017, and it was hard to get today's slide ready until this morning when finally the results came out. And I won't comment on whether that's a good or a bad result. We all make up our own mind. Unlike the two old men who have been president and will become president in this country, I have no disclosures. So let's start with, with Ehlers-Danlos syndrome. So who is that syndrome named after? Edward Ehlers was a Danish dermatologist who gave a talk in the early 1900s about what he called cutis laxa. And then Henri-Alexandre Danlos was a French dermatologist who gave a talk at the French Society for Dermatology and Syphilology, or syphilography, which was sort of interesting because my dad is a dermatologist, and as a kid growing up in the 1970s, we never had dinner before 9 o'clock at night because back then a lot of patients were afraid to go see a dermatologist because dermatology and syphilology, the knowledge about sexually transmitted diseases, was so closely intertwined. So my dad always had to have a lot of evening practice hours. Actually, although we never talked about that at the dinner table, in the 1970s, some people realized that the major manifestation of classical Ehlers-Danlos syndrome, which is the hyperextensibility of the skin, was actually first described in the 1600s by a surgeon from Amsterdam, Job van Meeke. And it's really fun to read his book. And he has a chapter about what's called a stretchable Spaniard, Mr. Albus. And what's really amazing about this book is that for each patient vignette, he'll write down the address of the patient and date of birth. And some of those addresses, when you walk through Amsterdam, those houses are still there. So really the correct nomenclature is the Van Meeke Ehlers-Danlos syndrome. And when I was a medical student at the University of Amsterdam in the 1980s, I saw a few patients who had this, what was then called type 4 Ehlers-Danlos syndrome. And Dr. Francomano, told all of us this morning that the current nomenclature is vascular type Ehlers-Danlos syndrome. And it really struck me when I saw this 16-year-old girl who came in twice to our ER when I was a medical student with TIAs, or mini strokes. And we just sent her back because we thought she was a drug addict because her skin was so thin. And then she came back the third time and she'd had a stroke from a carotid dissection. So it really made me wonder what it would be like, if physicians just don't believe you for whatever reason that might be. So that was back then, Ehlers-Danlos syndrome. I have a lot to be grateful for. I have a group of great colleagues in the CSF program we have. Talking about nomenclature, I think everybody will keep calling this spontaneous intracranial hypotension, even though we know when you do ICP monitoring, something I hardly ever do, or when we measure opening pressure, most of the time the pressure actually seems to be normal. It's a disease that in the beginning, 20 years ago, when we started seeing these patients, we saw just a handful a year. Now we see, more and more each year. And whereas in the beginning, it was clearly underdiagnosed, and it, of course, still is underdiagnosed. But there also seems to be a current trend in overdiagnosis of SIH. So out of the first 100 patients or so I saw for evaluation of SIH, the great majority actually met the criteria for a leak. Nowadays, it's about 1 out of 4 people who meet the criteria. And it doesn't mean that patients who do not meet the criteria don't have it. It just means that there's a certain amount of overdiagnosis. Like this is somebody I saw, I think, last year with headaches, and a very nice local neurosurgeon saw this scan, and on the left side that you can see here, there's meningeal enhancement, but it's not of the dura, really, it's of the leptomeninges. And he thought, oh, headache, meningeal enhancement. I saw something about CSF leak, so he sent it to me for workup for a CSF leak. But that actually turned out to be chronic meningitis. The 2 most important findings for SIH is brain sagging. It was first reported in the 1970s on pneumoencephalography. And then, of course, meningeal enhancement that was first reported by Dr. Barram Mokri from the Mayo Clinic. There are the other manifestations. SEEPS is a good mnemonic to teach your residents. There probably are some other ones, and as Dr. Ian Carroll told us about, that brain sagging seems to be very important, and there are different ways to measure that. Clinical manifestations, we all know there's a giant variety in how these patients can come to medical attention. But of course, headache is still the most important one. And certainly initially, the vast majority of these headaches are orthostatic. In the beginning, in the ICHD-2 criteria, it said it comes on within 15 to 30 minutes of being upright. You know, sometimes patients don't really get a headache until later in the afternoon. Now let's talk about some of the risk factors or associations with spontaneous leaks. Mainly, of course, the connective tissue disorders, which is why we're here today. And then there are some other associations. So the first patient I ever saw with a spontaneous leak was when I was a resident at the Mayo Clinic in Jacksonville. It was a very nice young lady who came in with orthostatic headaches. And just like the young patient from when I was a medical student, this patient also was turned away by many different physicians because of her headaches. She said she felt great after lying down. Nobody really believed her until she saw Dr. Folger, who was the chairman of neurology at the Mayo Clinic there at the time. And he said, oh, you know, this is a leak. We did a CT myelogram. It showed this a lower thoracic leak with the meningeal diverticulum. We took to the OR, operated on her. We never did a blood patch. Operated on her, and she did great. And we wrote this up because we thought it was fascinating. Back then, in the 90s, it was considered to be pretty rare, spontaneous intracranial hypotension. And because of my interest in Ehlers-Danlos Syndrome, I paid some attention to that. And she was very flexible in her joints. And when we submitted this manuscript, we included this photo that you can see there. But the editor-in-chief of the Journal of Neurosurgery at the time, who's actually at the University of Toronto, they said, oh, this has nothing to do with connective tissue. So we had to actually delete that picture from our paper. There have been, quite a few studies about connective tissue disorders in SIH. One of them is where we did some skin fibroblast cultures, and we looked at different staining methods with Wouter, who was then at Stanford, and Maurice Godfrey at the University of Nebraska. And what was interesting is they both find in the same patients similar abnormalities of the microfibrils. That's not specific for one specific protein or gene, but it does somehow lead us in that direction. Then when we looked at our first 18 patients only with SIH back in the early 2000s with Dr. Gordon, who's a geneticist here, we found that about 2 out of 5 people we thought had connective tissue disorder, these sort of atrophic scarring, the joint hypermobility. But when you actually look at that, right, so there's this really interesting study from Taiwan where they looked at 55 patients with SIH, and they compared it to a age and sex match control population. They actually found that the Beighton score, other joint hypermobility criteria, there was absolutely no difference between SIH patients and patients who did not have SIH. And the only statistically significant difference was in dolichostenomelia, which is where you have very long limbs. That was really the only feature that was different, but not joint hypermobility. We looked at it again with some other of the geneticists, the late Dr. Lemoyne. Dr. Weinstein was a visiting fellow from Israel. And everybody, at least years ago, used to talk about, a CSF leak gene. But as Dr. Francomano explained earlier today, it's really unlikely that you're going to find a single gene because it's probably a very heterogeneous group of disorders that can cause or can predispose patients to spontaneous intracranial hypotension. So, for example, this is a table that one of our residents put together a couple of weeks ago, where you can see that these are different type of syndromes or associations that have been reported with dural ectasia or with CSF leaks. And then also, when you think of connective tissue disorders, you think about the heritable connective tissue disorders, which are germline mutations, meaning that it's, a gene aberration throughout your body. You can also get acquired connective tissue disorders, of course. And then also, rarely you can have a somatic mutation. So this is an example of that. This is a young girl from Florida who, when she, around the time of her second birthday, whenever she would get up, she would say to her parents, "Oh, my head is on fire, my head is on fire." And she would lie down. And after a few months, she had an MRI scan done in Florida. And they found a Chiari malformation, as you can see here. Found a Chiari malformation. To look for a syrinx, they did an MRI of the cervical and thoracic spine. And they thought they found an epidural thoracic tumor, a very densely enhancing tumor. So they took it to the operating room. They did a beautiful Chiari decompression. They did a thoracic laminectomy. And they found all these tremendously dilated epidural veins. And they looked at the scans again, and they thought, oh, maybe this is not a Chiari with an epidural tumor. Maybe this is a leak. So actually, during surgery on this, at this time, Presley was 4, during surgery, they did a CT myelogram. So at the point of where they did the thoracic laminectomy, they did a tiny dural puncture. They injected some dye and then took her to the CT scanner. As you can see here, she's got these tremendous amount of dural ectasia, although here in the sacrum, this really looks more like an actual leak. And then after a while, she came out here, and I sent her to Dr. Lemoyne, the geneticist. I didn't really see anything on there, but what he found is that she had these, and it's a little bit hard to tell, I think, but she had these streaks, streaks of hyperpigmentation all over her trunk, starting at the upper thoracic level, down to her lower extremities. And Dr. Maya, the neuroradiologist here, did a epidural blood patch on her under general anesthesia, under evoked potential monitoring. And Dr. Graham, who's another geneticist here, he took skin biopsies, as you can see here. So this was done under general anesthesia. And he did the skin biopsies where half of the biopsy was part of the normal skin and half of the biopsy was part of the abnormal skin. And what they found in the abnormal hyperpigmented skin, an extra partial 10 chromosome. And the hyperpigmented streaks lined up perfectly with where she had these areas of dural ectasia. So this is an example of a connective tissue disorder, but it's a somatic mutation. It's not a germline mutation. Some of the other things we found are some, when you do scanning, electron microscopy, about 1 out of 5 patients have these abnormal elastic fibers, collagen fibers. We find aortic dilatation in about 1 out of 5 patients. And about 8% of patients who we saw with SIH had a brain aneurysm, and in the control population, it's about 2 to 3%. So we think that genetics plays a role, yet familial history, let's say a first-degree relative who also has proven SIH, is really, really rare. So we've seen about 1,500 patients with SIH, and only 5 of them have a first-degree relative with SIH. So now let's go to surgery. Surgery for leaks. What has really made surgery for CSF leak a very satisfying experience for me and my colleagues and residents? Of course, it's nice to work with really great colleagues and nursing, technician staff, monitoring staff. It's nice to have large operating rooms and a nice view from the OR. But it's really what's made a tremendous difference is advances in imaging. So it's not so much advances in surgery, it's really advances in imaging, and whether that's dynamic CT myelography or digital subtraction myelography. At Cedars, we've been using these DSMs. That's really what's made a enormous difference. So this is sort of our paradigm. I totally agree with Dr. Carroll that epidural blood patching should probably be done sooner rather than later. But if somebody comes in on a Friday, usually my colleagues don't like working on the weekends, so then usually put them on bed rest. We start with blood patching on Monday. If that doesn't work, you can repeat it. If you have a good target, you can try glue. And if that doesn't work, we do surgery. At least that's sort of the basic paradigm. Over the years, we have found that sometimes you really need to skip a few steps. So sometimes we go directly from there's a leak to surgery if we sort of know that the success rate of the different percutaneous procedures is going to be minimal. We try to be pretty practical. So even though we see a lot of patients from other parts of the country, other parts of the world, we also see a lot of local patients with CSF leaks. We generally don't do CT myelograms. We like doing heavily T2-weighted MRI scans, also known as MR myelograms. And just based on that, we do epidural blood patching, we do glue injections. I tend not to operate just based on an MRI myelogram. So then we go to the next step, which for us is the DSM. These are just some MR myelogram pictures. But it also really brings up, is it really necessary to look for a leak? Right? So for example, in some places in Europe, if you have somebody with orthostatic headaches and an abnormal brain MRI, they're going to skip the whole spinal imaging. It just goes straight to epidural blood patching. And there certainly is something to be said for that. It saves resources, it saves time. Because MR myelography, the heavily T2-weighted MRI scans are so non-invasive. You can have 5 MRI scans done a day if you want to. We usually do that. And it's not just because we want to know what's going on with the patient. And I feel we have a certain duty to find out different things about CSF leaks. It sometimes also can help the neuroradiologist or the anesthesiologist in knowing where to place the needle, where there's a good epidural space. And again, the real advances in the treatment of SIH have been advances in imaging. And that allowed us to really see, what are the different types of leaks. Type 1A leaks are the ventral tears. Those are oftentimes associated with a piece of bone. So as you can see here, there's this little calcified osteophyte that's piercing the dura. Dr. Peng talked about that too this morning. And then as far as connective tissue disorders are concerned, I think that in those patients who have the osteophytes and the ventral leaks, I think connective tissue disorders do play a role, but it's not as much of a role as some of the other type of leaks. So the 1B leaks, those are the lateral leaks. Those are also caused by a dural tear. As you can see here, usually not by a piece of bone, although on Tuesday I operated on somebody, coincidentally, his last name is Ehlers. I'm waiting for my first Danlos patient. Anyway, he had a lateral leak, and he had a piece of bone that had caused that, even though he was very young. He's only 35. So for the type 1B lateral leaks, I think connective tissue disorders play a much larger role, but also sometimes there's more of a local reason why they develop a leak. Type 2A leaks are the ones from arachnoid cysts. I think connective tissue disorders play a big role. Type 2B leaks, the dural ectasia type of leaks. I think everybody with dural ectasia has a connective tissue disorder. Usually we don't know the type. The type 3, the CSF venous fistulas, because most of those are associated with some type of meningeal diverticulum, and it's really a group. If you can find them, you call them CSF venous fistulas, but most of those can also be called ones that are caused by meningeal diverticula. So that plays a role, again, connective tissue disorders, but there are also some other type of manifestations. This is what these CSF venous fistulas look like. These are different DSMs at different time periods. And usually they're associated with a little cyst, but certainly not, as a matter of fact, usually not with the largest cyst. Sometimes you can have a combination of different types of leaks, even though that's pretty rare. This is a little video of one of these CSF venous fistulas. So here you see the diverticulum, and then here it starts filling the epidural venous system. This is another one. So here you see the diverticulum, and then here's the venous fistula. And I usually tell patients it's sort of like a leech that's sucking out spinal fluid rather than blood. Rarely you can find a de novo fistula. So that's a fistula that you don't see on the first scan, but you do see it on a second scan. So this is a lady with a diverticulum and the CSF venous fistula. I operated on it in the summer of 2018 or fall, and she did much better. Then some of her symptoms recurred. And then the next year, a couple of months later, we repeated the DSM, and we found that now she had a fistula up here at this level, whereas back a year earlier, you really don't see any evidence of this fistula. Sometimes these fistulas are really, really rare. I mean, very difficult to see. So this is somebody where there were no diverticula on their scans, on their CT myelogram. It was sent by a really, really good headache specialist here in the US. If it hadn't been for her, I probably would not have invited the patient to come over, just because everything was so normal and she didn't really get better with any blood patching. But then we found this tiny little diverticulum with a tiny little fistula. Here's the view under the microscope. So there's a little diverticulum. It's less than 1 millimeter. It's not related to a nerve root sleeve. That's over here. And that's the vein attached to it. I put a little clip on it, and the patient was 100% better right after surgery. Some of the other associations are these venous vascular malformations that we reported. This is a nice image. This is somebody I recently operated on who had this very large chest wall vascular malformation. She'd had some surgeries elsewhere where they weren't quite sure what it was. They'd done 2 biopsies. This is what this looks like at the time of videoscopic thoracic surgery. You see the hemangioma, and this is what the DSM looks like. So there's tiny little diverticulum here, maybe, and then it drains into this hemangioma-like structure. We tried to fix it with glue, but that was not successful. So she had to undergo surgery. And then other people have described exactly the same thing. I reviewed this really nice paper on CSF leaks and something that's called the blue rubber bleb nevus syndrome. But unfortunately, the other reviewers didn't think it was that good, but I'm sure we'll see it published somewhere in the near future. And maybe there are some other associations. This is a lady with one of these fistulas, and she had this very odd-looking spine. You can see that the vertebral bodies here are different colors. Nobody knows why. Everybody says, oh, she must have had radiation as a child. She didn't. She has these spontaneous spinal fractures. What's another risk factor? Dr. Gray talked about that this morning too. Maybe some people get these leaks, certainly CSF venous fistulas, because there's an underlying high CSF pressure states. And some of my colleagues in neurosurgery kind of make fun of me because they say, Wouter, you fix a leak, but it's because the pressure is high, and then they'll just pop up somewhere else, like this game of whack-a-mole. And these are just some patients who are very obese, and their opening pressures are markedly elevated. Now about the bony spicules, that's an important thing to look at. Sometimes, however, they just resorb over time. And certainly it's not always the largest spicule. So if you have a patient with a ventral leak and multiple spicules or just one, you really always need to do more testing to really find out exactly where the leak is coming from. And then when you find a tear, you can suture it. For the cyst, you can place clips on it. So if somebody has one of these ventral leaks and the symptoms have been going on for more than a couple of months, we don't do blood patches or glue anymore. We just take those patients straight to surgery, because when it's become more of a chronic leak, 99% of patients, I think, will require surgery. It's a little bit different for other type of leaks, like the lateral leaks, the CSF venous fistulas, the arachnoid cysts. Certainly glue or blood patches is a good way to treat that. And if that's not successful, then you can go to surgery. Surgery, of course, has risks to it. Infection, causing leaks. That's really the main risk of surgery, is that because you work around the spine, around the dura, so there's a significant risk, about 3% here, of causing a CSF leak. When we have a ventral tear, I like to operate those patients from the back. You can also do it from the front, but then you have to do more extensive surgeries. This number, right, 98% success rate, that's the radiographic success rate of surgery, not the clinical success rate of surgery. So even people who no longer have a leak that we can find on MRI or CT myelography or DSM, I think about 15–20% or so of those patients still have symptoms, either just as bad or just somewhat improved since surgery. And that's a very challenging patient population. I like to show these pictures of different ventral leaks. I think they look kind of pretty. You can buy wallpaper made out of this at Cedars if you ever come over. You can also easily take out the little bony spur through a posterior approach, as you can see here. This is the bony spur. I sort of fragment it so it's easier and therefore safer to remove it. That's the underlying tear, and then you can suture that. So when you see the tear and it's near the spinal cord, but not really right in the middle, it's easy and safe to suture it. But sometimes the tear is right in the midline underneath the spinal cord. And for those patients, I use a little muscle graft, and the success of these surgeries seem to be identical. For the lateral leaks, I think it's important as surgeons to realize that so this is a little foraminotomy. You've drilled up some bone. This is a membrane you'll find, but you actually have to open that up to get to where the tear is. And if you don't do that, or you put like some sling around it, then the leak will continue. And you really have to open it up and identify the underlying dural tear. These are just different examples of CSF venous fistulas. Sometimes they arise from the nerve root sleeve, but sometimes they don't. then you don't have to sacrifice the nerve root. There are some delayed sequelae, superficial siderosis, pretty rare, but probably not as rare as most patients or most physicians realize. Here are some MRI scans of patients who have a ventral leak and then either have bleeding within that ventral collection that you can see here, or they have bleeding within the subarachnoid space that you can see there. And that's probably the cause of superficial siderosis. If you have a very large extradural CSF collection from a ventral leak, you can get stretching of the cervical nerve roots, and that can cause something that's called bibrachial amyotrophy, which can be devastating. I'll show you this picture of a lady who lives here in Beverly Hills in a nursing home, and she really cannot move her arms. This has been like this for 7 years. And we did fix her leak, but there hasn't been any improvement. Another delayed sequela is spinal cord herniation. So sometimes the spinal cord can herniate through one of those dural tears and can cause weakness and sensory abnormalities in the lower extremities. I'm sure I'm way over my time. Thank you very much.